or live?
Who's going to start? I guess I'm going to start. Welcome back to Unremarkable Labs. We are going to try to do quite a few more this academic year. And we're really fortunate to have one of our great residents, Dan Weintraub, to present a case to us. And as usual, um, our uh, we're working with Dr. Natasha Mira, who is really the brains behind this, and I'm Bob Centaur, in case you didn't know. Dan, tell me the
It's an
story.
honor to be here with you guys. Thanks for having me and letting me present this case to you. So we have a 61-year-old gentleman with a history of metastatic small cell lung cancer. He has mets to his liver and his adrenals and multiple lymph nodes. He's had a long hospital course. He originally presented for planned inpatient chemotherapy, actually induction chemotherapy. This is newly diagnosed. But he's had a really long hospital course. It's been complicated by tumor lysis syndrome, acute SVC syndrome that required stenting. He's had multiple malignant pleural effusions, which we've had to drain, kind of recurrent on that right side. He's developed paroxysmal AFib now with RVR, hospital-acquired pneumonia, hospital-acquired delirium, you name it. He's been here for like a month. We've kind of resolved all these acute issues. He's several weeks out now from his chemotherapy, and we're getting ready to discharge him, and that's where y'all will come in. I guess we can kind of move on, to some of his history. So you know about the SCLC, the SVC syndrome. He did have a stroke previously, left-sided. He has some right-sided residual deficits. The paroxysmal AFib was a new diagnosis here, and then he's got COPD as well, long-standing smoker. His medications, so he's carboplatin and etoposide induction therapy. He's getting phos packets twice a day. He's getting, albuterol as needed. He's also getting like duonebs and hypertonic saline. May have omitted those. Aspirin Plavix for his stroke. He's rate controlled with metoprolol. He's got some allopurinol for his, TLS kind of prophylaxis stuff, benzonatate tabs, and some loperamide as needed for diarrhea. Exam wise, he's afebrile, heart rate's in the 90s. We got him decently rate controlled. His pressure's fine. He's setting 92% on room air. You guys want some physical exam stuff?
Is it going to help me? But I understand the problem is labs. Let's go straight to the
The
labs
problem is
because
really
it's more fun
labs.
that way.
I like it. So here's his metabolic panel and CBC, so just kind of basic stuff.
Okay, so I notice he has some mild hyponatremia. I'm not surprised that he has some mild hyponatremia. He's probably under a lot of stress and producing some ADH, and I'm not going to get excited. He does have hypokalemia, and I'm going to be interested in what is causing the hypokalemia and whether that's been a chronic problem, whether we need to worry about it. His bicarb is stone cold normal. I really only look at the chloride to calculate the anion gap. The chloride by itself doesn't really help me. Um, BUN of 6, he's probably not eating great. That's sort of a low BUN, but he's been real sick. Creatinine 0.5 probably doesn't tell us at all what his renal function is because he's probably quite cachectic. And if I really cared about his renal function, I would probably get a cystatin C, but I probably don't care about his renal function. But I'll keep that in the back of my mind. Uh, the reason that you get a low creatinine like that, and I'd be interested in what it was in the past, is to take into consideration his muscle mass is probably down. When your muscle mass is down, your estimated GFR goes up, but it's not a real GFR. But we get to the real crux of the matter. And so the calcium 8.2 corrected. Tell me what you mean by 8.2 corrected. Is that the number that the lab gave you and then you corrected it? Or did they give you a number of like 6.5?
It was like 7.2 and corrected
Okay.
for albumin. Yeah.
Okay.
And that his
Because the
ionized is like 1.09 as well. If that's
yeah,
useful for you.
which is not it's not a perfect thing. Uh, but what has you excited is a phosphate of less than one. And phosphate of less than one is potentially lethal.
Yeah.
So one of the things that I teach all the time on rounds is what you have to worry about with phosphate of less than one. And I think it's good that this is a video because I'm going to act a little bit here. The first thing you think about is the brain, and you can actually die from seizures from hypophosphatemia. You also get altered mental status. The next thing is the heart, and that's the best way the easiest way to die because you can get uh, VFib, and I unfortunately saw a case of that I didn't personally see it, but I had to discuss a case of that once of a patient who came in with a phosphate of about 0.7. You also get heart failure because you need phosphate for muscles to contract. And so this can exacerbate heart failure. And it's even postulated, at least in one place I once read, this might be why people who have alcohol use disorder and have severe heart failure from alcohol use disorder can recover so completely because they think there might be a decrease in intracellular phosphate because you need it for ATP. Um, it's a good story, even if it's not true. Um, then you think about the lungs, and you get hypoventilation because you need your intercostal muscles to breathe well. Um, then you think about the about rhabdomyolysis. Again, the same reason you need phosphate to avoid rhabdomyolysis, and you can get acute kidney injury, which he doesn't seem to have. And finally, you can get hemolysis because you need ATP to maintain the red cell membranes, and you're more likely to get infections because you need phosphate for white cells to work well. So I'm worried about all those things in this guy. I'm going to try to correct it. Most people who get hypophosphatemia get it because of refeeding syndrome. And let's think about that. So what happens is in order to make ATP, we need uh, to have phosphate around. And when we're making ATP, uh, let's start that again. Rather than talking about ATP, let's just talk about handling glucose. So let's say you haven't been eating, and all of a sudden I give you glucose. And during the time you haven't been eating, you continue to lose phosphate. Now you have glucose. Glucose wants to combine with ATP and do stuff, glycolysis, gluconeogenesis, etc. So you use up a lot of phosphate. The phosphate can go down very rapidly. That's refeeding syndrome, but it can happen the other way. Let's say you have a lack of, and you need insulin to do that. So let's say you have a lack of insulin. So one of the classic hypophosphatemic syndromes is diabetic ketoacidosis. You give insulin, you have plenty of glucose around, and you use up phosphate real quickly. This is why most pediatric ICU doctors give K-phos rather than KCL to kids with brand new diabetic ketoacidosis. But it's the same idea both times. It's combining glucose and insulin and using up phosphate. So I'd wonder, given his lower BUN and all the problems he's had, of whether or not his phosphate could be low from that. What I would do is I would aggressively give him phosphate. And if you look into up to date, for example, and see how much phosphate you can give more than that. And
Yeah.
you have to give aggressive phosphate. And I'm sure Dan has looked at this up and can teach us that at the end. Um, So that's one possibility. We don't have any signs of hyperparathyroidism, but this is really low for hyperparathyroidism. The other that carboplatinum can cause all kinds of renal dysfunctions. I haven't looked up whether it could cause this one or not. Um, but you usually with Vanconis also get a normal gap metabolic acidosis, and you also get glycosuria with a normal glucose. So I'd at least get a urinalysis. Do you happen to have a urinalysis?
We did get one. I didn't include it for the purpose of space, but he did not have glycosuria.
Yeah. So he probably
That's a
doesn't
great
have
question.
Fanconi syndrome. So I'm going to look back and see how much he's been eating, and hopefully just giving him some phosphate will make him better. If it's not that, then I'm going to have to go and look up whether carboplatinum can cause phosphaturia, because I know it can cause all kinds of renal things. In looking at his list here, I was trying to figure out whether or not this could be whether you'd get hypophosphatemia as part of his tumor lysis syndrome. Um, and I know with tumor lysis you get high uric acid, you get I think you get hypophosphatemia, and um, you get high potassium. Help me, Dan.
Yeah. So no, and you're right. This is like you're right on the track of kind of what we were thinking too. So the top of our differential initially was also refeeding syndrome. He has the hypokalemia, which kind of supports that. He's an oncology patient. So that's what we thought first. But what kind of gave us pause was just the sheer amount of phosphate this man was requiring. He was getting
Yeah.
IV phos every day, sometimes multiple times a day. We kept giving him phos packets to try to get control of it and just couldn't get it under control. And tumor lysis syndrome, as part of the process of both renal, dysfunction and renal failure, and also lysis of cells themselves, you actually get hyperphosphatemia.
Hypophosphatemia.
And that causes precipitation of stones in the kidneys, which, exacerbates sort of, the renal failure in addition to the uric acid, that precipitates as well. So, the hypophosphatemia would not quite fit with tumor lysis syndrome.
I th I think at this point what you want to do is you want to, and I have to look up, and you'll be able to tell me, but I think you can do a fractional excretion of phosphate and see whether or not he's losing it through the kidneys.
You got it. My favorite lab, I think, that I've ever ordered. So yeah, I
So
think I
So
can.
let's just discuss fractional excretion because everybody's heard of the fractional excretion of sodium, but they forget that fractional excretion is a term that tells you how the tubules are working in the kidney for any particular uh, molecule. And so the idea here is that we want to know what percent of the phosphate that is being filtered is being excreted. And with hypophosphatemia, you would hope that would be a really low number, but if it's a high number, then we know the problem is there's a tubular phosphate dysfunction. And then I just have to go look because I've never seen this before myself in 50 years, so I'd have to go to the books to figure out what it was. But I know that'd be the next thing I'd do.
That was, you're ahead of where we were because, our team only figured out, to do a fractional excretion of phosphate from literature review, and kind of trying to figure out how to work this up further. But you're right on. So we did get a
So
fractional excretion of phosphate.
he's losing a ridiculous amount of phosphate. So
Yes, sir.
I think vitamin D deficiency can cause that. Hyperparathyroidism probably can cause that. And I assume and I just have to look up and see whether or not carboplatin can cause that. Because I've never heard of it, but I know that that class of drugs can do all kinds of bad things to the kidney.
And we did measure vitamin D. I'll kind of, if Natasha, if you don't mind me
Yeah.
just exposing some of these labs here. I don't know how you guys order them typically. So
Oh
we
yeah.
did, we checked PTH, which was normal. We checked, 25 hydroxylated vitamin D, which is normal. We also checked a 125, which was low. Um, and we got an ABG as well. He's a little bit tachypnic. We were thinking about, intracellular redistribution, um, tiny bit alkalosis, but not profound.
Yeah, so the low 125 vitamin D is interesting. Um, the most time that I worry about 125 vitamin D is if I'm looking for a cause of hypercalcemia. Uh, and I'm looking for a high 125 telling me that it's sarcoid or Hodgkin's or uh, something in that ballpark. It being low, I'm not sure what caused it to be low, but I think that could have some influence on the hypophosphatemia. So now I have to go back and look and see why it can cause hypophosphatemia. I'm still real worried about the carboplatin.
And we actually only have, I think, one more lab um, left to reveal. If you guys are ready, or I don't know if we want more discussion thoughts or not.
I don't know, Natasha, is there anything else that I should talk about?
Do we just want to talk about what the filtration of the phos,
Well, I mean, he's excreting almost
all of
half of
it?
the phosphate
Yeah.
that's entering the tubules. So there's something's wrong with the tubules. I don't know whether vitamin D would cause that.
Yeah.
I have a feeling this is much more significant
I guess
injury.
I'm
Yeah.
wondering what lab test I would order to try to get an answer. I kind of want to know, or I kind of want to brainstorm what lab I would even go next, because if you give it to us, I wouldn't have thought necessarily to order it myself. So,
Well,
um,
you know what you can do is you can pull out a book or a website and say what causes a high fractional excretion of phosphate.
exactly.
I can do that right now. So I'm going to
Sure.
demonstrate the way I really take care of patients. I'm going to go to Perplexity.
Is that
and
the
I would like to
AI?
point out that this is exactly what we had to do. I mean,
Okay.
we were, where you guys are at this
What
point.
causes a high fractional excretion of phosphate? Decreased renal function, excessive dietary phosphate, hormonal factors, tubular dysfunction, medications, some drugs, and they don't tell me the drugs, and metabolic acidosis. So I'm going to blame it on a drug. I want, yeah, so maybe a carboplatin level. I don't know. I want to blame it on carboplatin. Whether I'm right or wrong, that's where I'm going right now. I'd search on that.
What happened to our screen? Make it bigger.
Beautiful.
There we go.
Okay,
Okay.
teach us something, Dan.
All right. Well, I guess at first, just because you guys asked more about the fractional excretion of phosphate. So, a normal fractional excretion of phosphate in URI, 5 to 20%. So even just like a normal state, somebody who has normal phosphate, he's elevated. And typically, if someone, is hypophosphatemic, the kidney's capacity to reabsorb phosphate is like outstanding. You can get near 100%, reabsorption. So, we would expect him to be less than 5% at least with his profound phosphatemia. So we were lost, obviously, as well. And this is a bit of a zebra. So, just so you guys know, this was not something that any of us had ever heard of.
Good.
What we ended up diagnosing here. So if you guys want to reveal that last lab, I guess now is a decent time. And so
Oh,
a
how
bit clue
cool is
here.
that?
Have you
How
heard of
cool is
this?
that?
Yeah.
So, so why
So
does so FGF23 is a phosphatonin, and
mhm.
phosphatonin means it causes you to get rid of phosphate. Uh, and I talk about it sometimes because with kidney disease, the first thing that the the first thing that you do when you're trying to adjust for minimal metabolism is the phosphate goes up, and so therefore the FGF 23 goes up. That eventually stimulates PTH to go up. I have no idea why the FGF 23 is elevated, and you're going to teach me.
I'm gonna try. I'll teach you. So this is actually a paraneoplastic syndrome.
Mhm.
Um,
Wow.
yeah, and this is a very atypical presentation as well of this particular syndrome. So the syndrome is most commonly referred to as tumor-induced osteomalacia or TIO, and caused by an overproduction of FGF23. By tumor cells, essentially. Or there's other mutations related to cleavage. FGF. There's multiple ways to end up with this same phenotype, but essentially it's an overproduction of FGF23. It's most commonly seen in mesenchymal tumors. So it would kind of make sense, like
Mhm.
osteoclasts, make FGF23. So you more commonly see it in like soft tissue bone type tumors. And it's usually like somebody who comes in just kind of, weakness, maybe some multiple fractures that you can't explain. The most common tumors are very small and benign and hard to find that cause this. So, small cell lung cancer, there's case reports, but it's pretty rare, for it to be associated with this syndrome. Um, but what FGF23 does is you're exactly right. It's a phosphatone, which I had never heard of these. So Dr. Centaur, I'm impressed that you do that off the dome. Um, but yeah, so it regulates phosphate in multiple ways. So first of all, it's a transcriptional regulator, and it actually like inhibits transcription of the sodium phosphate co-transporters in the kidneys, which are primarily located in the proximal convoluted tubules. So, thereby inhibiting phosphate, reabsorption. It also regulates alpha 1 hydroxylase expression. So if you remember back to the 125 vitamin D, being low, that's kind of the explanation, it looks like. So, FGF's through the roof, inhibits alpha 1 hydroxylase expression, and thereby, causes low 125 vitamin D levels. So then now we're kind of a dual, phosphate issues. We're not absorbing, right? We don't have 125 vitamin D. So from the gut, we're not absorbing. That's why it was so hard to control his phos levels just with the oral phos packets. And then we're secreting, huge amounts of phos because our kidneys are unable to reabsorb.
That is incredible. That is incredible. Um,
And
so I assume you could give IV phosphate.
and that's what we had to do. And this is kind of what tipped us off to something going on. Because it's just every single day we're giving like 45 millimoles of
Mm.
sodium or KFOS just every morning. And when you're on the onc service, you see a lot of cachectic patients. You see a lot of people with just temporal wasting. He didn't really look like that. You'd go into his room, he'd have like a bag of McDonald's that was empty, like that he just like, and his wife was going out and getting him fast food. And so originally we were thinking like, this is just, we've seen this a million times, it's refeeding syndrome, it's poor intake, that kind of thing. But, over time we kind of had to question that because when you compared him to our other patients who had been malnourished for years, had much longer, histories of cancer, he just didn't have the appearance of somebody who was that severely malnourished. And it had been, weeks since he'd gotten induced with chemotherapy.
That's
I'm glad you
incredible.
guys like this case.
It's
Oh no, I love
fascinating.
it.
So
I
we
love
don't
it.
we don't have like a IV, or we don't have like any kind of phosphatone inhibitor or medication for
Not
that,
that
I'm guessing. This must be so rare.
exactly. So usually what they do is they remove the tumor. Again, it's normally like a small, benign. I mean, really, like it's a hard diagnosis to make. People think it's pretty underdiagnosed. So it's usually just a small, benign, slow-growing mesenchymal tumor that just produces this FGF. It takes years to diagnose because the symptoms are so vague, weakness,
Mhm.
bone pain, maybe some fractures, stuff that we just see in older patients anyway. They get, referred to room, all kinds of other people. Um, and part of the reason it's so hard to diagnose is because we don't have FOS on our basic metabolic panel. So if you're going to a primary care physician, you're not routinely getting your FOS checked. So,
Well, that's why
it
everybody
can,
should get a renal function panel.
I agree. As a future nephrologist, here.
It's
uh,
actually when I'm on service, I found that the renal function panel does not cost more than the basic metabolic panel. So I tell my teams to get renal function panels. That way you get MAG and FOS also, and you never know when you might need those. The thing that is fascinating is so FGF23 is fibroblastic growth factor, and the reason I know it's a phosphatidylcholine is um, when you're looking at why you get secondary hyperparathyroidism, what what why you get secondary hyperparathyroidism, the reason is, and at least when I saw some studies a number of years ago, it's in response to FGF23, not in response to vitamin D. Everybody thinks it's because vitamin D is down, but that's not the reason.
Okay.
The reason is the FGF23. And so I've always known about FGF23, and I know that it goes up very early in when you have significant chronic kidney disease. But I'd never heard of this syndrome. And it makes total sense that if you had too much FGF23, because I knew what a phosphatidylcholine was, and I knew that it has a very good purpose in trying to maintain our phosphate and not give us hyperphosphatemia. So this is wild. I mean, I guess what he did he I assume you were able to overcome the problem with IV phosphate. And I guess if he was going home, he'd have to periodically have IV phosphate because you're not going to be able to overwhelm his oral phosphate.
yeah, I think the unfortunate outcome of this case is, this was a send out lab. We were able to get his phosphate under control with just like a ton of phos packets, basically,
Mhm.
as outpatient. But unfortunately, I think right around the time that this send out came back, he got readmitted. He was in the ICU, developed, respiratory decompensation, and
Yeah.
unfortunately passed away. His phosphate was normal at that time, so probably not related to the hypophosphatemia
Yeah.
being poorly controlled, probably, just kind of his underlying disease.
Mhm.
Um, but yeah, and it is tough. Like Dr. Bureau was saying, it'd be ideal if we had some kind of an inhibitor of this molecule or something. But right now, all you can really do is remove the primary tumor if feasible, or just supplement. Really hit them hard with oral, and if you need to
Mhm.
get periodic IV, you got to do what you got to do. So tough to treat.
Yeah.
Very, very tough to treat.
Well, I love this for a couple of reasons. Number one, it gave us a chance to talk about hypophosphatemia, which I think is very important. Um, and just in sort of the in ending this for everybody who's watching this, always worry about people who are cachectic, especially people who drink alcohol, because alcohol increases fractional excretion of phosphate. And so people who drink a lot and don't eat, you can usually tell because they had a very, very low BUN. But those people, even if they come in with a normal phosphate, on day 1 or 2 might develop hypophosphatemia. So you have to check people who are heavy drinkers for a couple of days after they come in. They don't always come in because phosphate is mostly intracellular. You can be profoundly phosphate depleted, but have enough phosphate in your serum. So you have to look for it. The same thing happens with diabetic ketoacidosis, by the way, that if you don't give phosphate, it takes a day or two before you can get the insulin and the glucose to work together. So don't feel reassured when someone's admitted if they have a normal phosphate. If they're really cachectic and susceptible to one of these refeeding syndromes, check it. Measuring FGF23 here is absolutely brilliant, Dan. I'm so glad that you brought this case to us because it helps us understand the physiology even better and understand an unusual but obviously important complication of this tumor. Natasha, you get the final word.
Yeah, thank you so much for sharing this. Like Dr. Centaur said, it's a great review on physiology, which I love. And, doing Unremarkable labs for all the time I have, I've learned so much physiology. And honestly, I have fallen more in love with the kidneys and admire and respect what they do over the years, learning from Dr. Centaur. So thank you so much once again. And sounds like you took great care of this patient. Unfortunately, in his case, he passed away. But I'm sure he was very grateful to have you as a doctor.
Thank you guys. I'm really glad you guys enjoyed this case, and it was a lot of fun to be on with you. And I learned a lot already from Dr. Centaur. I was doing some reading in the background here, but some of these learning points I'm gonna need to review. And then also your question about carboplatin. I need to look that up because that was not really on our radar of potential cause. So I'll have to dig into that a little bit and see if
I know it causes a lot of renal dysfunctions. I don't know if it causes this one.
yeah.
And if it does, we'll have to do
A follow-up episode.
a follow-up episode.
An addendum episode.
Around it.